Good morning, everyone. We'll get started in just a moment as people join. Just to remind everyone, this session will be recorded and we will share a link to the session after the webinar is completed. Again, good morning, good afternoon, good evening, everyone. We're just waiting as people join on at the top of the hour. A reminder to everyone, this session will be recorded and it will be shared once the session concludes for you to listen again if you'd like. Okay, I think we will get started. Sarah, if that's okay. Great. Good morning again, good afternoon, and good evening to our colleagues in Southeast Asia. Once more, we will be recording this session. It will be available by link later on, and we will have hopefully two speakers. We have one connection issue, but hopefully that will be resolved. And then we will have approximately 15 minutes for questions. You can put your questions into the Q&A box, and our communications team led by Hugh and Sarah will be available to moderate and look through the questions and make sure that we cover as many of them as possible. And thank you all for joining us today. We're very privileged to have a very topical agenda item, as well as two specialists, experts in the area of epidemic control, and from Resolve to Save Lives, who have been a partner with us. We're going now into our fourth year with a program in Sierra Leone supported by Resolve to Save Lives, who have really been wonderful to work with over the last 3 years. I would like to introduce our two guest speakers. The first is Dr. Stacy Mearns. Stacy is the Director of Epidemic Ready Primary Healthcare, I think a term that we're all gonna hear more and more about in the future as the years to come, at Resolve, where she leads strategic development and coordination of the Epidemic Ready Primary Healthcare Initiative. She has a wealth of experience in the health sector, including 9 years in humanitarian emergencies and outbreak response. She is a physician and member of the Royal College. Secondly, I would like to introduce Dr. Mohamed Lamord. Dr. Mohamed is the project director of 717 Alliance at Resolve to Save Lives. So in addition to Epidemic Ready Primary Healthcare, I'm sure we're going to hear a lot more over the next few years around the metric of 717. He works across countries to support achievement of the 717 targets for outbreak prevention and control. Previous to joining Resolve, he was at the Infectious Disease Institute of Uganda for 15 years, leading global health security appointments. He was appointed by the Minister of Health to lead Uganda's efforts on the COVID-19 response, as well as the recent outbreak of the Sudan strain of Ebola in Uganda. He also works in the area of antimicrobial resistance, and he is a physician with a doctorate in clinical pharmacology. So I'd like to introduce Stacy first to begin the presentation. Thank you, Stacy.
Great, many thank you, Susan, and good morning, good afternoon, and good evening, colleagues. I'll just go ahead and share my slides with you all. There we go, perfect. So I'm very pleased to have the opportunity to discuss one of Resolve to Save Lives' newest areas of work, Epidemic Ready Primary Healthcare. So I will take you through how we landed on this topic area, what Epidemic Ready Primary Healthcare is as a concept, how we achieve it, and what we are currently doing at Resolve to Save Lives. So the COVID pandemic highlighted major gaps in primary healthcare systems around the world. We saw huge challenges with the integration of public health functions and primary healthcare services. In many places, core public health functions such as surveillance, testing, and contact tracing either fell through the cracks or were assumed by newly created teams or by hospitals. System fragmentation hampered the efficient flow of patients, of staff, of supplies across health system levels in many countries. And many countries were unable to leverage successfully primary healthcare infrastructure to rapidly roll out the COVID vaccine. In the face of the demands of the pandemic, primary healthcare systems around the world struggled to continue to deliver routine essential health services, resulting in disruptions in the delivery of routine immunizations, maternal and child health interventions, care for infectious diseases other than COVID, as well as non-communicable diseases. Healthcare workers around the world were inadequately protected. In many places, already stretched healthcare workforces were stretched even further, leading to staffing shortages and burnout. Many primary healthcare facilities were ill-equipped to handle the surge in demand caused by the pandemic. Insufficient infrastructure, limited testing capacity, inadequate PPE, and shortage of essential medical supplies all pose significant challenges in delivering care effectively and safely. We also saw huge challenges with information overload in terms of rapid changes in information, guidelines, and protocols, as well as misinformation and distrust. And this is not an exhaustive list. The list of challenges and learning certainly goes on and on. But the point I wanted to make is that these key learnings really do underscore the importance of strengthening primary healthcare systems, building resilience, and investing in preparedness to mitigate the negative impacts of future epidemics or pandemics on primary healthcare facilities and critically the communities that they serve. Now, the primary healthcare system is often the first point of contact with the health system, representing the front door to the vast majority of health systems around the world. And as such, well-prepared primary healthcare facilities can serve as an important first line of defense in detecting and responding to epidemics, helping to prevent outbreaks escalating to epidemics and pandemics. Now, you will hear more about 717, but a review of Resolve to Save Lives 717 work found that the majority of outbreaks that were analysed were detected at the primary healthcare level, and that the vast majority of bottlenecks for detection and notification also existed at this level. And interestingly, the most frequently observed bottleneck to detection was low awareness or clinical suspicion by healthcare workers. So these findings clearly highlight the need and opportunity that exists to strengthen epidemic preparedness at the primary healthcare level. And it was really these findings, coupled with learning from COVID, as well as the work Resolve to Save Lives was supporting at primary healthcare facilities to improve infection prevention and control, was the birthplace of our thinking about epidemic-ready primary healthcare. So epidemic-ready primary healthcare fundamentally is an approach to support resilient primary healthcare, which is a primary healthcare system that can prevent, prepare for, respond to, and learn from infectious disease outbreaks, whilst continuing to deliver essential health services. It centres on connecting and integrating the public health functions of epidemic preparedness and response with the health service delivery functions of primary healthcare at the point of delivery. It's very much about bridging the gap that exists between these two spheres at multiple different levels. So at the health facility level, how core public health functions are integrated with service delivery packages. At the national level, how best to integrate functions held by national public health institutes with those held by ministries of health. And at the global level, how best to align and integrate global policy agendas, be that global health security, universal health coverage, or primary healthcare. And epidemic-ready primary healthcare is important for a long list of reasons. Firstly, to ensure early detection of infectious disease threats, which is key to enable a timely and effective response. If infectious disease threats can be detected early and contained locally, this will influence the scale and duration of outbreaks and is core to preventing epidemics. It's important for ensuring the continuity of essential health services during outbreaks. We've seen from the pandemic and with previous Ebola epidemics that outbreaks can have a significant impact on the delivery of essential health services, resulting in significant levels of morbidity and mortality that are often far greater than the outbreak itself. It's also important for protecting healthcare workers and patients. Healthcare workers are vulnerable to infection during outbreaks, and their loss represents a significant loss to the health system for many years to come. And also in terms of potential cost savings, investing in epidemic preparedness at primary healthcare facilities could lead to substantial cost savings in the long run. By preventing the escalation of epidemics, the health system avoids the financial burden associated with large-scale outbreaks and their aftermath. So how do we get there? Well, a useful starting place is thinking about specific capacities health facilities need to be epidemic ready. For example, an epidemic ready primary health facility should be able to provide preventative services, diagnose and treat disease, detect new outbreaks promptly, which requires a high index of suspicion amongst frontline health workers, notify the appropriate authorities within the right time frame, collect and send appropriate specimens, and provide appropriate and timely care, support outbreak prevention and response activities, maintain quality of care, essential services, and healthcare worker and patient safety during outbreaks. And lastly, and certainly not least, and serve as a trusted source of information and services for the community. So epidemic-ready primary healthcare will involve interventions to strengthen health facility capacities in effective surveillance and early warning systems, safe health service delivery, ensuring a protected and epidemic-ready health workforce, and ensuring connected, engaged, and protected communities. And this is just an example of some of the health security capacities needed at a primary healthcare facility to be epidemic ready. But capacity alone is not sufficient to achieve epidemic ready primary healthcare. There are key health system enablers that must also be strengthened. And this is critical because the health facility capacities required for epidemic readiness are not implemented in a vacuum. They're implemented as part of and through the health system, principally the primary healthcare system. And so the strength of that system will have a relational impact on the attainment and use of those capacities. So in addition to thinking about epidemic-ready primary healthcare from a health security capacity lens, we must also think about it from a health system strengthening lens. And there are many different components required across the health system to achieve epidemic-ready primary healthcare. The picture on the screen gives examples of these different components across the health system building blocks. So for example, under leadership and governance, there's a need for mechanisms to support coordination between primary healthcare departments, which are usually housed within the Ministry of Health, and national public health agencies, who are typically responsible for epidemic preparedness and response. There's a need to involve and integrate primary healthcare into health security plans and epidemic preparedness and response plans. And despite the important role that the primary healthcare system plays during epidemics, clear policies regarding primary healthcare functions and roles during epidemics are either lacking or underdeveloped. In terms of health system financing, there's a need for increased primary healthcare funding across the board, including the establishment of emergency financing mechanisms that can enable rapid release of funds in the event of emergencies to the local level quickly. Under the health workforce, there's a need to increase the availability and compensation of healthcare workers. Globally, there are still large health workforce gaps. Adequate training, including public health and public health emergency management competencies for frontline health workers, efforts to ensure the safety and protection of healthcare workers through improving infection prevention and control, inclusion and support for community health workers who have vital roles to play in epidemic preparedness and response. Under service delivery, integration of core public health functions into primary healthcare services, be that surveillance and early warning to enable prompt detection and reporting of notifiable diseases and unusual health events, case management inclusive of clear referral pathways across the system, and vaccination, both proactive and reactive vaccination. Preparedness plans and ability to rapidly access resources for maintaining the delivery of essential health services in the event of a health threat, and proactive community engagement to build trust, establish feedback, expand outreach activities, etc. Under medical products, stable and reliable logistics and supply chains are needed to ensure the availability of medications, diagnostics, and personal protective equipment, access to point-of-care diagnostics, and quality assured and timely laboratory networks, appropriate wash infrastructure to support infection prevention and control. And under the health information system, there is a need for a well-integrated health information system that allows primary healthcare providers and facilities to closely monitor populations, identifying changes in disease patterns and service demand in real time, that is inclusive of multi-sectoral risk monitoring and early action, promoting bidirectional communication and information sharing across health system levels. So again, this is not an exhaustive list, but to give you an idea of the breadth and the depth of actions required across the health system. So achieving resilient primary healthcare requires the integration of health security and health system strengthening. It can't be achieved with an emphasis on one without the other. Simultaneous approaches to strengthen core health system enablers or building blocks are needed alongside efforts to develop and strengthen health facility capacities for health security, ensuring that primary healthcare systems can prevent outbreaks, detect outbreaks, respond early and effectively, whilst maintaining the delivery of essential health services. And this approach centered on integration can pay double dividends with reduced mortality and morbidity and the socioeconomic costs associated with epidemics and health emergencies, but also overall strengthening of primary healthcare delivery at large and the associated improvements in health and well-being. Now, this is by no means a quick nor an easy task. It requires a fundamental shift in our approach to healthcare governance, financing, a more effective integration between public health and health service delivery, between global health security and health system strengthening. Increased political and financial commitments are needed, and importantly, they need to be sustained long after the memory of COVID has faded. Multi-level interventions are needed, in particular ensuring health security capacities at all levels of the health system and not just at the national level. Now, I think we can all agree that primary healthcare plays a crucial role in epidemic response. There's limited research and guidance on practically how to ensure epidemic preparedness and readiness at the primary healthcare level. The evidence base is weak concerning which specific interventions countries should implement at the primary healthcare level to improve resilience. What are the capacities at the health facility level required for epidemic readiness? How do we best achieve these, sustain these, and scale these? What is the optimal model for public health and health service delivery integration? And what does this look like at different levels of the health system? How best do we bridge the gap between global health security, universal health coverage, and primary healthcare in terms of policy, funding, and implementation? And how can these different agendas support one another to advance resilience? What is the cost of achieving epidemic-ready primary healthcare, and how cost-effective is it compared to not acting? So we certainly have more questions than answers at this stage, and questions that are very important to address. To support addressing some of these questions, Resolve to Save Lives in collaboration with partners will prototype a programme for epidemic-ready primary healthcare in Nigeria, Sierra Leone, Ethiopia, and Uganda, And we're very honoured to have ICAP Sierra Leone as a partner in this project. And the goal really is to prototype and test an implementation model that integrates critical public health functions with health service delivery, strengthening capacities for epidemic readiness at primary healthcare facilities that can be scaled and sustained, as well as demonstrate the important role of primary healthcare within health security. And so the initial focus of this pilot centres on ensuring a safe and protected health workforce and safe health service delivery through strengthening infection prevention and control, ensuring effective surveillance and early warning systems at the primary healthcare level to strengthen the prompt detection and reporting of potential outbreaks, strengthening public health emergency management approaches to ensure the continuity of essential health services in the event of a health threat, as well as supporting linkages, coordination, communication, and data flow between health service delivery departments of ministries of health and national public health agencies. And the core intervention package of this pilot will include continuous quality improvement and workforce development, utilising a mentorship model to support capacity strengthening at the health facility level, strengthening health facility and district or subnational level preparedness through the establishment of contingency response plans, referral pathways, stockpiling of commodities, simulation exercises, etc. Use of data to inform action planning and performance improvements, and to inform policy and procedures at the subnational, national levels, and also strengthening bidirectional communication, coordination, integration between primary healthcare facilities and local district public health officials for data use, reporting, monitoring, outbreak prevention, response activities, etc. And then also at the national level, strengthening engagement and coordination between primary healthcare departments and national public health agencies. And so these interventions will be implemented across different levels of the health system, from the health facility to the subnational to the national level. And we're really hoping that through this pilot to be able to learn, refine and adapt approaches, both for impact, scale and sustainability. So in summary, primary healthcare plays a critical role in epidemic prevention and control. And Epidemic Ready Primary Healthcare aims to integrate critical public health functions with health service delivery to increase the readiness and resilience of primary healthcare to detect and respond to outbreaks whilst maintaining essential health services. And achieving Epidemic Ready Primary Healthcare will require increased and sustained financial and political commitment, effective integration between public health functions and health service delivery, intentional integration and linkages between global health security and health system strengthening, intentionally combining health security capacities with strengthening health system enablers, and ensuring that these capacities are present at the primary healthcare level and that primary healthcare systems are included as a core part of advancing health security. And it's not a question of if health systems will face an epidemic in the future, but when. And I think COVID has shown the world that fundamental change in health systems is needed. So as we emerge from the pandemic, there is an opportunity to better connect, align, and bring together what has become in many places the fragmented realities of global health security and health system strengthening. And I will stop there. Thank you for listening. I'm very happy to take any questions.
Wonderful. Thank you so much, Stacey, for that very clear presentation. We do have some questions coming in. I think what we will do is go straight to the next presentation and then open up for questions. Just to confirm, Sarah and Hugh, Dr. Mohammed hasn't been able to join, correct?
Correct.
Okay, no worries. I will go through his slides as best I can, and then we will make sure to leave plenty of time for Q&A. And we already have some questions coming into the Q&A box. Thank you, Jill. And others, please put in your questions or your comments into the Q&A box to allow us to have a lively discussion. So let me go ahead and I will humbly try to present this for Dr. Mohammed, who was on with us just a little while ago, but is having some connectivity issues from Kampala. So what I'm going to present is what I think is a very nice, and something I really like about Resolve to Save Lives is their very practical approach to service delivery improvement. It is always rooted in the real world and not overly theoretical, and very, very practical. So I'll present on their 717 framework, which is an effort to improve timeliness and effectiveness of public health responses. Next slide. So public health events are any event that represents an immediate threat to human health and requires prompt action. As we all know, one of our most precious commodities during the early days of the COVID-19 outbreak was time to marshal an understanding of what was happening, time to get people on board to how we come together to catalyze an effective response, and time to get communities empowered to protect themselves. So implementation of control and mitigation measures are what we talk about prompt action, that ability to quickly implement control and mitigation. Next slide. And this map shows just the enormity of outbreaks that have been seen. There have been 152 discrete events measured since only June of this year, so roughly 1 month ago by WHO Africa, a total of 127 outbreaks. And this includes measles, meningitis, Lassa fever, cholera. We're now seeing cholera outbreak in South Africa, typhoid, acute watery diarrhea, ILI or influenza-like illnesses, coupled with humanitarian crises, monkeypox, anthrax, dengue fever, and the list goes on. But this is just a very powerful picture to show us the enormity of outbreaks that are happening at any one time in this case in the Africa region, but we could look at this across the world as well. Next slide. So the challenges are many, and we all know that they are, because of climate change, increasing. I've got a new word in my daily vocabulary. What is the air quality? And that is directly related to climate change. I'm actually up in the Adirondack Mountains, and I'm struggling to see across the lake that I am on because of the Canadian wildfires that are coming through and affecting the Adirondack Mountains of northern New York. So climate change is a very real issue that will continue to increase and impact our health, our individual health, and public health. We also have the encroachment and zoonotic spillover. Mohammed, would you like to take over? I see you're on.
So thank you very much. We really had a telecommunications interruption here. I apologize for that.
No worries, no worries. I'm happy to hand over to you. Please go ahead.
Thank you. So yes, climate change is really one of the drivers of the increased number of suspected outbreaks and confirmed outbreaks that we're seeing. Climate change is resulting in changing of the habitats. We have vectors such as mosquitoes and ticks that are then able to spread beyond their original geographic scope and cause disease elsewhere. Zoonotic spillover is particularly important because many diseases, particularly viral diseases, seem to be coming from the animal sector and then affecting humans. Everything from viral hemorrhagic fever to rabies, are zoonotic illnesses. But we're also particularly concerned about unknown diseases. So some viruses that reside in the animal population, we may not even be aware of their potential to cause disease in humans. But as we interact more and more with the animal sector, we're increasing the possibility of seeing not just disease in a few people, but full-blown outbreaks. Increasing population, but not just increasing population, but increasing population as well as high mobility of populations. People may get a disease in one territory and then travel to another location and spread in a different location. People may go across borders, and we've seen cases including of Ebola in West Africa that was able to travel across neighboring country borders, but also by air travel reach all the way to Nigeria. Misinformation, disinformation, perhaps an area we never concentrated a lot on before, but right now we recognize that our public health efforts are really dependent on the cooperation of the public. And if the public does not take the prevention messages, if they don't take appropriate action to protect themselves, we find out that we're spending more to control outbreaks, but unfortunately also finding out that more people get sick and die from disease. And the lack of therapeutics and vaccines is really important. For many of the viral diseases, from Rift Valley fever, Ebola Sudan, Ebola Bunibujo, Marburg, we find that we don't have approved therapeutics and vaccines. And so when we find yourself with all these challenges, what you really want to do is to keep the outbreaks small, because if the outbreaks are small, then your resources are able to be deployed in an effective manner to control it without having so much loss of life and economic disruption. Next slide. And so what is 717? 717 is an organizing principle. It's a target. It's also an accountability framework that we're using to make the world safer from epidemics and pandemics. Next slide. And this graphic is what I want you to really remember. We want it to take no more than 7 days for us to detect a public health threat from the time of it.
Great.
This might mean that, the date from which someone starts having symptoms of a disease like Ebola. It may also mean that, conditions like measles, we notice a cluster of cases, but it could also mean that what we expect in terms of the frequency of an endemic disease has suddenly increased. Regardless of how we recognize that there is a suspected outbreak, we do not want to take more than 7 days to detect that this has occurred. And detection can be done by just recognizing, the clinical syndrome and a public health or a clinician, records that this is a suspected case of maybe polio. Or it could mean that, you've done a rapid test and the rapid test has ruled out other common illnesses, and now you suspect an outbreak-prone disease. But once that point has been met, it should take no more than 1 day to report to public health authorities that something has occurred. And then once public health authorities are informed, they should take no more than 7 days to complete an initial early response. Next slide. And it's not just about the time. It also includes, whether those responses that we're providing are effective. And every public health event is for us an opportunity to learn and to improve. For example, if we're able to find out that it took us long to detect because there weren't trained clinical staff, then we can then implement clinical training for those staff. And so what we want to do is to use each of those outbreaks as an opportunity to then learn and improve, and then identify areas where we can improve for the future. Next slide. And so let's look at performance improvement for a single event. Next. So you have here, you want to capture and assess 717 performance, right? You want to get the information about that outbreak. Was it possible for us to detect within 7 days? Did we notify public health authorities within 1 day? Were we able to complete an initial early response within 7 days? Next. And so here again, we have that framework: emergence to detection, notification, response, the end of the outbreak, and then the post-event. Next. And so you want to do this in real time when an event is ongoing. So when you do it when an event is ongoing, then you're able to check during the event and see if there are measures you can take immediately to strengthen your response immediately after your outbreak has been detected. Next. But you could also do this after the event has been completed, and this is called a retrospective review. And retrospective reviews can include looking at material, at information about the outbreak in the past, through after action reviews. And those retrospective reviews can also give us valuable information as to some of the challenges that were being faced. Next. And these challenges, we call them bottlenecks, right? Bottlenecks hinder timeliness. They cause delays in us being able to achieve what we expected to gain in the 717 framework. And when we identify bottlenecks, we think of how can we solve them. But we also have enablers. There are things that support us and facilitate timeliness. And we want to actually keep a record of both. So what hinders timeliness, we look for improvements and ways to overcome. What facilitates timeliness, we seek to strengthen by supporting with advocacy, documenting them as best practices so that others can also refer to those actions and strengthen their own responses. Next. And for those bottlenecks for which you already have immediate resources available during the outbreak, you quickly implement immediate actions, and you want to implement them as soon as possible so that you can affect the overall outcome of your outbreak response. Next. But as we know, sometimes we don't have everything we need, in which case we have to plan in future for future outbreaks. We have to ensure that we document what the gap is and mobilize resources over time and then deploy those resources so that we have a stronger response in future. Next. So let's summarize. How can 717 improve public health action? One, through performance improvement. Our delays and bottlenecks are easily identified, and not just identified, this information can then be shared with relevant stakeholders to drive rapid improvement. In addition, we're able to prioritize for financing and system strengthening. We then figure out which actions that we want to spend money on will help us in terms of timeliness. And then we can also use it as communication and advocacy tool because sometimes political leaders may not understand our complex epidemiology or case management or risk communication jargon. But when we talk about 717, it's really easy for political leaders to recognize what we're trying to accomplish and then provide not just resources, but also their own support to ensure that we're able to deal faster with outbreaks. And in terms of accountability and reporting, we really need to be able to look back and monitor our performance, evaluate our interventions, and be very transparent about how we handle outbreaks, given the huge economic and human toll that they can cause. Next slide. So we've talked a lot about the theory around 717 and why we think it will work, and but what exactly happens in real life when you use the 717 targets in a country setting? You review past outbreaks. What do we find? Are countries doing very well, or are countries really facing significant challenges? Next slide. So this study was a retrospective study conducted in Brazil, Ethiopia, Liberia, Nigeria, and Uganda. And 41 public health events were purposefully selected to see whether these events met the 717 targets. And just about half of them were detected within 7 days of emergence. The median was 6 days. So that means many others exceeded the target. 71% were able to meet the target of being notifying within 1 day, and this is commendable. some of the things that enable early notification, simplified reporting forms, the use of electronic communication, the use of telephones, all these measures that have been put in place by surveillance teams seems to be working in terms of ensuring that when a threat is discovered, it can be escalated quickly. But when it comes to early response actions, less than half, only 20 out of the 41, met a target of 7 days to complete all early response actions. Now, this is not the entire response. We actually have specific activities that should be done within 7 days, like setting up an incident management team, deploying risk communication, infection prevention control, medical countermeasures, in society, public health social measures. These measures must all be initiated within these 7 days for us to be able to say that we have completed the early response actions. And sometimes the challenge has to do with surveillance, contact tracing, sometimes it's resource mobilization, sometimes it's just absence of the skills for these issues. And this is an area for improvement. But overall, if we looked at it as a single complete system, only 27% of events, or 11 out of 41, met the complete target from detection, reporting, and early response actions. Next slide. Recognizing the importance, last year in August, African health ministers voted to adopt the 717 target across the WHO Afro region, to use it as a tool to really accelerate efforts to rapidly detect and control outbreaks in the region. Next slide. But just after it was adopted, a month later, we had to test this in a real-world setting. And in September 2022, Uganda's Ministry of Health reported an outbreak of Ebola Sudan virus disease. The date of detection was 17th September 2022, but when the 717 framework was applied, we realized that more than 40 days earlier, the outbreak had emerged. And the failure of detection was due to a bottleneck that was quickly agreed upon. Patients had presented in private health facilities with a myriad of symptoms that could have been Ebola, but the private facilities did not recognize and did not suspect that these patients had Ebola. The reason why that happened is that much of our training had prioritized the public or the government-owned facilities. And so private facilities had not been aware of case definitions. And it was only when a patient went all the way up to a regional referral hospital that the disease was detected. Also, failures in our community-based surveillance and deaths that had been occurring prior to the detection of the outbreak were not recognized and surveilled. In terms of notification happened within a day, and it's important to commend that. But when it came to response, the initial response took as many as 9 days. And part of the difficulty was, being able to identify an appropriate isolation unit within 7 days that could manage the patients. We had challenges in terms of the numbers of patients, both suspected and confirmed, as well as issues in terms of facilities within isolation units. The second critical challenge in terms of response was delays in accessing funds for a rapid response team to conduct contact tracing for all the people that had been potentially exposed. And it was only by bringing out these issues through 717 that partners were identified who could then immediately deploy their own resources and send out contact tracing teams that eventually led to the very strong response that we had overall for this outbreak. And so even with a response like Ebola Sudan that is praised highly in terms of the technical expertise that was deployed, the speed, the coordination, the ability to detect cases in different parts of the country, 717 is able to show us some of the immediate gaps that we can address, but also bring to our mind some of the long-term issues where we should treat the entire health system, not just the public alone, as part of our surveillance system, and strengthen capacities throughout to ensure that when these cases are present in any facility in our countries, we're able to deal with them and identify them. Next slide. And so this slide is really about the 717 Alliance. And the 717 Alliance has been set up to really support countries to adopt 717 with the support of technical assistance, tools, but also to provide country grants, catalytic country grants, so that countries are able to initiate reviews of their system, start presenting data on 717 for all outbreaks, share that information, even use that information to prioritize particular areas where they might seek additional funding to address gaps in the health system. 717 is also going to help us create a global community of practice and learning. Much as it's a simple metric, as you can see, it gets quite complicated when you have to think of all the things that are necessary to be completed for a single outbreak. And you need expertise by pillar, particularly when it's time for response. And so this community of practice and learning will help us to build the necessary capacities to strengthen not just the timeliness, but the effectiveness of our early responses. And the last is operational research, so that wherever 717 is being implemented, we learn about how it's performing, which new questions need to be answered, and how best we can strengthen implementation for future countries that might take it on. With those, thank you once again for your attention. It's been a pleasure presenting this.
Thank you, Dr. Mohammed, and very happy that you were able to join back in. Appreciate it. So we have a number of questions in the Q&A box that we would like to ask Dr. Stacy and Dr. Mohammed. I'll get right into the first ones here. The first one is from Jill Gay. Has any country effectively accomplished what you have in the slide, so this is to Stacy, on epidemic ready PHC components across the health system? So that is the first part of the question. And then the second is for the health worker. She's making a comment, there is a need for policies and enforcement on violence against healthcare workers. So firstly, has any country effectively accomplished these epidemic ready primary healthcare components that you described? Over to you, Stacy.
Thanks, Susan, and great question, Jill. I think the answer to that in short is no. And why? I mean, I think we've seen the best example of a real world test to the whole system with the COVID pandemic. And I think, you know, there hasn't been a health system or country around the world that hasn't, you know, struggled under the weight of COVID. I think, you know, countries have approached sort of global health security, health system strengthening in different ways. I think one of the challenges has been that in many places, global health security and advancing global health security has often been quite siloed outside of the health system. And I think, you know, looking back at COVID, when you look at the metrics for global health security, be that the Global Health Security Index, be that, you know, IHR capacities, even countries that scored very well on those metrics really still struggled with their COVID responses. And I think, you know, certainly for me, that really highlights the need to be looking at how best do we bring together and integrate how we think about and approach health security into and under the lens of health system strengthening. There are some countries that probably are a bit further advanced. I think Thailand is probably a good example, where actually if you look at sort of policy level, you know, their global health security sort of national action plans, their policies and plans under universal health coverage, all actually have a health system strengthening lens that sort of ties them together. So I think for me, for epidemic ready primary healthcare and these components, it really is about how do we actually look at this through the health system, and how do we actually also ensure that whilst building the capacities for better preparedness in the future, that we're also strengthening the system as a whole. And your comment is well taken too. I think we definitely need to think about the healthcare workforce on multiple different levels, and how health emergencies and outbreaks impact healthcare workers more than just their physical protection with infection prevention control. Thanks.
Wonderful. Thank you for that response. The next is from Venus Mushaninga. And Venus asks, will the scope of the work of Resolve include a component on recovery as well? And I think this could be both for Stacey and for Mohammed. To what extent are we bringing in metrics around our recovery as well? So let me start with Mohammed and then over to Stacey.
So yes, I think within 717, the focus has really been the acute period. The rationale for focusing on the acute period is that we know that if you implement 717 with rigor, then you end up with a smaller event. So faster responses will lead to smaller outbreaks. And then those smaller outbreaks then have a smaller impact on society. And then, recovery then is you spend less really on recovery. However, thinking about recovery is also critical. And Stacey might comment a bit, you then need large, potentially government platforms that are already existing. So you don't necessarily have to look for large new injection of new resources. If you strengthen the system that already is present in that country, it can then lead up and support recovery efforts. Stacey, if you have a comment around that.
Yeah, thanks, Mohammed. I mean, I think the component of recovery is certainly included within epidemic ready primary healthcare in a number of different ways. And I think an important point to make is if we actually are better prepared and have readiness, capacities developed and situated within health systems, then we should expect to see shorter outbreaks. We should expect to see outbreaks that don't become epidemics or pandemics. We should expect to see, the scale also being different. And I think all of this is important too, because that then affects the sort of depth of recovery that is required. And I think, one of the key points of epidemic ready primary healthcare is actually ensuring how do we enable the continuity of essential health services during a health crisis. And I think, to date, there are very few examples of that actually being done well. And that becomes, an enormous area of focus during recovery. So I think, there is, and I think when you think about the health system's sort of lens and the different capacities, the capacities required to respond to an epidemic within a health system are quite different to the capacities and resources required to recover, which is also still very important. So I think for us, certainly on a conceptual level, as we further sort of flesh out epidemic ready primary healthcare as a concept, recovery is absolutely a part of that. In terms of our sort of pilot project, less so, because the emphasis on the pilot project is more on the preparedness side of things. Thanks.
Great. Thank you so much. The next question is from James Smith. Hi, Stacey and Mohammed. He's really fascinated by the presentation. James's question is, do you believe the conversation around epidemic preparedness is prevalent to the learnings of graduate students as they enter school and ultimately move forward to work in the workforce post-graduation? To what extent is epidemic preparedness a part of their learning and their training? And in your opinion, how do you believe Gen Zers can play a role in addressing epidemic preparedness? So this is for both of you.
I could start off. I mean, one of the critical things that we have to do in health security generally is to ensure that a lot of these important concepts become part of pre-service curricula. So while people are in school, but before they join the workforce. Unfortunately, for many areas in health security, including preparedness and response, much of the training is in service, and that's part of the reason why we have the challenge that I mentioned. So if I'm a health worker and I'm employed in a government hospital, and the government is responsible for outbreak preparedness and response, I'm more likely to be trained than another health worker who works in a private hospital. But the probability that a patient with a suspected outbreak will go to the government versus the private, is not known. And so by bringing education pre-service, right, health security education, bringing it pre-service, we are essentially ensuring that all our health workers can, put their best to keep our countries safe and secure from epidemic threats. Gen Z are playing an important role already in terms of, for example, detecting outbreaks, being able to, explain to communities around public health measures. We see risk communication changing from what the government told me to what we learn from our peers. We see this in social media as well. And so Gen Z plays an important role in terms of taking on new technologies that can reach large numbers of people. And then hopefully by integrating the right knowledge around the outbreak, they're able to transmit information that can help us to keep outbreaks small as well.
Great. Thank you for that comprehensive response. The next is around from Jill. I would love to believe that clear data can influence policy. And as we know, there were a lot of national examples where the data was dismissed or the data was not utilized fully to create a strong and effective response. I can say, though, from our work in HIV and the 95-95-95 strategic targets for epidemic control of HIV, I believe, have really been a powerful force, a powerful measure to show how far many countries have come through long-term investment in HIV service delivery. And I believe, and I'm optimistic, that the 717 targets, like the 95-95-95, can spur added attention and understanding of how far we've come in many places, but also how far we need to go. And I think some of the data that Dr. Mohammed showed was very striking, how far we have to go as far as preparedness and responsiveness. I believe the link to the retrospective study was shared, and both, I believe, are from the Lancet. The next question is from Yanis. Should a pandemic be considered some type of biological war, in which case all the workers in the sector are conscripted to work for free? And this is definitely a challenge that we see where healthcare workers are not protected in the medical sector. Would one of you like to respond to that question?
So I can give us, an initial thought around it. I think we recognize that epidemics and pandemics can come, from what is known as dual use research, where people can manipulate pathogens, and in manipulating pathogens, they make them more infectious. However, I think we also have to keep in mind there are thousands of viruses in nature already. A single bat may have as many as 2,000 pathogens, that it lives with. And we don't even know what those do. So in our heads, we know that these outbreaks will happen naturally. And it's inevitable that we will have outbreaks based on all the things we described in terms of the challenges earlier. We just need to put in measures, to protect and prevent these outbreaks. And then in the sector where we believe that there is potential for dual use research, we have to strengthen regulation, education, screening of those people that can actually work in those types of laboratories, and have very clear controls from a biosecurity and even cybersecurity standpoint of those facilities to minimize any risk of that playing a role in future outbreaks.
Thank you. Thank you for that response. We're at time, and I'm sorry, Victor, we did not get to your question, which I think is a really, really excellent question, whether the Epidemic Ready Primary Healthcare and 717 are applicable to disaster management as well. And we will hopefully devote time in the future to that. At this time, though, I would like to hand back to our communications team, to Hugh and to Sarah, to present for the next webinar. And thank you again to Dr. Stacy and Dr. Mohammed for your wonderful presentation, and to all of the audience for your participation and tremendous questions. Over to you, Sarah.
Thank you, everyone, for joining. Our next grand rounds will be Tuesday, August 15th, and it'll be at 9 a.m. on HIV, mental health, and beyond, how research could protect youth in a rapidly changing world. Thank you so much and have a good day.
Thank you, everyone. Goodbye.